three important paraproteinemia which I wanted to tell you right now. 1, 2, 3. Clinical association, they are prone to transform into this kind of event. So first patient will be coming and they will be asymptomatic MGUS. Then they will be converted into asymptomatic smoldering multiple myeloma, and after 15 to 20 years, they will be converted into the frank multiple myeloma. So that is why we should know all these things, right? As I said that my MGUS patient is usually asymptomatic. So there will be no symptom. You will understand after some time. That's all. You will understand after some time, asymptomatic. Similarly, smoldering multiple myeloma will be also asymptomatic. You will understand after some time. But here they will be having symptoms. You will understand after some time. Right? So what are the findings you will see in monoclonal gammopathy of unknown significance? Remember, there are only three findings. There are only three findings you will see in these disorders, right? So in monoclonal gammopathy of unknown significance, when you are going to check the bone marrow biopsy, plasma cell count will be less than 10%. So remember, plasma cell count is less than 10% on bone marrow biopsy, right? So bone marrow biopsy, plasma cell count is less than 10%, right? Clear? So plasma cell count less than 10%, M protein will be less than 3 gram per deciliter. So when you are going to see there M protein in the serum, that monoclonal, M means monoclonal. So monoclonal protein which is present in serum will be less than 3 gram per deciliter, and there will be no evidence of, remember, no evidence of end organ damage. No evidence of end organ damage. So these are the three findings you have to remember for MGUS. Only these three things will be seen, and if you see conclusively, only two findings are seen. That's all. Plasma cell count less than 10%. Serum M protein less than 3 gram per deciliter. That's all. Otherwise, no other finding will be there. That is why asymptomatic. Same way, smoldering multiple myeloma will be also presenting. See that here it was less than 10%, less than 3 gram. Here it is more than 10% and more than 3 gram per deciliter. That's all. All other findings are same. No evidence of end organ damage. So smoldering multiple myeloma, plasma cell count is more than 10%. M protein is more than 3 gram per deciliter, and there is no evidence of end organ damage. Right? There is no evidence of end organ damage. So that is the true, right? So now understood. So multiple myeloma, how it differs. M protein is the monoclonal protein. I have told you. I think. M means monoclonal. You remember I was telling you, kappa or lambda chain only, right? Kappa, either kappa or lambda. So this is the monoclonal protein, right? So that light chain is forming protein, that is the monoclonal protein, right? So now understood. So in case of multiple myeloma, plasma cell count is more than 10%, just like smoldering multiple myeloma. M protein is also more than 3 gram per deciliter, just like smoldering multiple myeloma. But what is the difference? Difference is the evidence of the end organ damage, and that is why they are symptomatic. If there is no end organ damage, asymptomatic. No end organ damage, asymptomatic. For example, if examiner asks you MGUS, will you find anemia? Anemia, bone lysis, renal failure? No. All these things are absent because there is no evidence of the end organ damage. No evidence of the end organ damage. Bone fracture, anemia, renal failure, all these symptoms will be visible in the multiple myeloma. So now understood. So that is what I wanted to show you, that no evidence of the end organ damage, and evidence of the end organ damage is responsible for the symptom or no symptom. What is the, how we are going to measure the end organ damage? Now the question is coming to your mind, how we are going to calculate the end organ damage? So end organ damage is measured by a standard acronym criteria called as CRAB criteria. Remember, this is given by WHO. This is not mnemonic created by us, right? This is a WHO criteria mnemonic, right? Which stands for C. So there are four things: C, R, A, B. CRAB. So what is CRAB? What is CRAB? Hypercalcemia. C for hypercalcemia, renal failure, anemia, and bone lytic lesion, right? So now you can see that these are the C, calcemia, renal failure, anemia, bone lysis. So these are the end organ damage. So this is how you will measure the end organ damage, right? So all these things, see what I have said, evidence of end organ damage will be present only in multiple myeloma. So all these findings in MGUS will be absent. Now understood? In MGUS, all these findings will be absent. So that is why I said end organ damage will be not seen in all those MGUS or smoldering multiple myeloma. Clear? Fine. See, all these things are interrelated. Now listen to me. How these are beautifully interrelated, I'm going to explain. See this bone lysis. Bone has been fractured. So bone is required for the RBC hematopoiesis, right? RBC hematopoiesis. So because of the bone lysis, what will happen? Anemia. Right? Clear? Because of the bone lysis, anemia, and when bone will be having fracture, what will be released from the bone? Calcium, hypercalcemia. So if there is a more calcium in the serum, where they will go? They will come to the urine, causing renal failure. So now understood. Bone lysis leading to anemia, bone lysis leading to hypercalcemia, and hypercalcemia leading to renal failure. So these are all beautifully leading to hypercalcemia, and hypercalcemia leading to renal failure. So these are all beautifully interrelated to each other. Right? Fine. Now come to the multiple myeloma. What is multiple myeloma? It's a B cell problem or disorder. When you will see T cell B cell disorder, these are the T cell B cell disorder, right? These are the B cell disorder which will be forming abnormal plasma blast or plasma cell tumor. Plasma cell tumor is also written as abnormal plasma blasts, right? Abnormal plasma blast means tumor wala, right? So these are the abnormal plasma blasts. So why abnormal plasma blast is formed? Abnormal plasma blast is formed because of which cytokine? You remember in inflammation when I was teaching you the most important cytokine, and that time I told you it's a factual point, but when we will progress in our pathology discussion, it will be coming so many times in our discussion, right? So plasma 6, right? So IL-6 is for the plasma cell, IL-6 is for the plasma cell proliferation, right? So because of the abnormal increase in the IL-6, there will be abnormal plasma cell formation. And remember, multiple myeloma, most important cytokine for the pathogenesis. So remember, this is the most important cytokine in the pathogenesis of multiple myeloma. So that was the question in the AIMS exam. Most important cytokine involved in the pathogenesis of the multiple myeloma is IL-6, right? So now I understood why B cell will be converted into abnormal plasma cell because of the IL-6, right? Now, what will be the problem with this neoplastic plasma cell? That is again a very important and beautiful thing. Neoplastic plasma cell, this concept, I'll tell you, this is not theory. This concept will lead to clinical aspect, how to differentiate the multiple myeloma from the other condition, right? Fine. So what is the criteria? What is the thing you have to understand in the neoplastic cell? Neoplastic cell will be releasing two important things, right? One is the MIP1 alpha chemokine, and second is they will be activating the WNT pathway activation. These are the two things you have to remember, right? Neoplastic plasma cells are going to release a chemokine, or you can say cytokine, and they are going to activate the WNT pathway activation, right? So because of the MIP1 alpha is macrophage inflammatory protein 1 alpha, macrophage inflammatory protein 1 alpha. Right, so macrophage inflammatory protein 1 alpha is CC chemokine, right? So we have read in the inflammation topic. These are the CC chemokine, right? So second group, second family, beta chemokine, right? So what will happen? The CC chemokine or macrophage inflammatory protein 1 alpha, they will increase the expression of the rank ligand on the bone marrow stem cell, bone marrow stromal cell, or bone marrow osteoblastic cell, right? So both can be expressed. What is the problem? If there is more rank L expression, remember this increased rank L is required for the osteoblast activation. I will tell you when I will be teaching you bone pathology. That time I will be telling you how rank L and rank interaction. Rank is present on the osteoblastic cell, and rank L will be present on the stroma or osteoblastic cell. I'll just show you here for the sake of your knowledge. Suppose this is the osteoblast or stromal cell, right? They will be having increased expression of the rank L, right? And these are the osteoclast precursors, which will be having rank, right? So this rank, when they will combine, remember, when this rank will be combining with rank L, then only this osteoclastic precursor will be transforming into the osteoblast. That is the simple basic concepts of the bone pathology, right? So this is the simple basic concept of the bone pathology. Right? So this is the simple basic concept of the bone pathology. Stromal cells, they have rank L ligand. Osteoclastic cells, they will be having rank receptor. So when rank L and rank will be combining, then only this precursor will be converted into mature osteoblast. And this mature osteoblast, what is this osteoblast? What is the osteoblast? Modified macrophage of the bone. So what they will do? This modified macrophage of the bone is going to eat the bone. So because of bone eating, there will be hypercalcemia. So now you understood why there is a hypercalcemia, and this hypercalcemia will be causing the renal failure. Right? So now you understood that is the important thing which I wanted to tell. Neoplastic plasma cells will release cytokine, which will increase the rank L expression on the stromal cell or osteoblastic cell. This will allow more maturation of the osteoblast. Osteoblast is the modified macrophage of the bone marrow, and this will increase the bone eating. And because of bone eating, calcium will be high, and that is the reason for the renal failure in this patient. Here, this is the one part. Second part, neoplastic plasma cells will activate the WNT pathway. Because of the WNT pathway activation, what will happen? They will inhibit the osteoblastic cell. So that is the very important thing. Osteoblast, remember, osteoblast activity is estimated by serum alkaline phosphatase, right? If osteoblast is more active, alkaline phosphatase will be more. If osteoblast is more active, alkaline phosphatase will be more, right? Alkaline phosphatase will be more. So when osteoblast is inhibited, alkaline phosphatase will remain normal, right? Because our body is having normal serum alkaline phosphatase. When it will increase, whenever there is an increased osteoblastic activity, and when they are blocked, we will be having normal only. Don't think that it will be decreased, right? It will be normal. It will be increased when there is a more osteoblastic activity, and it will remain normal if there is inhibition of the osteoblast, right? So now you understood that plasma cell is activating both things, osteoclast also and inhibiting osteoblast, right? So there are two functions: activation of the osteoclast, inhibition of the osteoblast. So what is the usefulness of this point? What is the usefulness of this point in our clinic? A patient will come to you. He will be having sudden fall, he will be having fracture. And now you have to understand whether this fracture is because of the trauma only or because of the multiple myeloma. So I understood. So when it is a multiple myeloma fracture, you can order serum alkaline phosphatase. Serum alkaline phosphatase will be normal here, whereas in the traumatic fracture, osteoblast will be activated. So because of the osteoblastic activity in traumatic fracture, alkaline phosphatase will be increased. I understood. And that was the question in the exam also, right? So that is the pathological fracture which we are seeing in the multiple myeloma. So whenever there is osteoblast activity, there is an increase in the serum alkaline phosphatase. So osteoblastic activity is in all except. Can you tell me the right answer for this question? This was the question in the AIMS exam and NEET exam. Serum alkaline phosphatase will be increased in all except football for this thing, right? So bone fracture, yes, it will be increased. Paget disease, osteoblastic cell will be osteoblast. See, in all three things which I have written here, right? In all three things, you will be having both osteoblast and osteoclast activation, right? Osteoblast and osteoblast both will be activated. So because of the osteoblastic activation only, there is an increase in the serum alkaline phosphatase in all these three conditions, right? So that is how question will be asking in your exam. Now, come to the multiple myeloma. When you are seeing the multiple myeloma, brown tumor is hyperparathyroidism. How hyperparathyroidism? Fracture is there, na? Brown tumor में fracture होगा. Because of the hyperparathyroidism, there will be the fracture, and because of the fracture, there will be osteoblastic activity increase. That is why they will be having increase in the serum alkaline phosphatase. Brown tumor is the fractured bone which will be having blood accumulation, and that is the reason. And that fracture is because of the hyperparathyroidism. What will be the clinical finding? Males are commonly affected, and age group will be slightly older, 40 to 70 years age group will be there. In Robbins it is given 60 to 70, but some books say 40 to 70. Nothing matters, right? If you remember like this, it will be better thing because we see more cases in this age group, right? So 40 to 70 years, male bone lytic lesion is the most common presentation, right? Normocytic normochromic anemia will be the peripheral smear finding. So that was the question in the AIMS exam, right? Normocytic normochromic anemia. So multiple myeloma, normocytic normochromic anemia will be there, right? Now coming to the multiple myeloma, as I have told you, there is an increased plasma cell, right? And this abnormal plasma cell will be forming abnormal in the AIMS exam, right? Normocytic normochromic anemia. So multiple myeloma, normocytic normochromic anemia will be there, right? Now coming to the multiple myeloma, as I have told you, there is an increased plasma cell, right? And this abnormal plasma cell will be forming abnormal M protein, right? Abnormal M protein is monoclonal protein. So what are monoclonal protein? These are the light chain, either kappa or lambda. You remember either kappa or lambda. So many students they get confused at this point. See, this is the line of Robbins which I have written here, and this is the line of Wittrup also, right? So both books they have mentioned which I have written here. All the light chain immunoglobulin will be formed. All immunoglobulin will be forming the light chain. IgG, IgA, IgM, IgD, IgE, all will be forming, right? But when examiner is asking you, so remember IgG is the most common and IgE is the least common. Right, because this was the question in the NEET 2017. Right, which of the following light chain immunoglobulin is not formed by multiple myeloma? IgG, IgA, IgM, IgD. So that time D was answer because E was not given. So that is why I have given you entire scenario. This is the decreasing order of the monoclonal light chain protein. IgG is the maximum. See, the mnemonic is game DE. Right, so don't make the game DE. Right, so remember them game DE, game DE. Don't remember GAME. Many students they remember GAME. It's not like that. It's not like it's a gum day in Hindi. Okay, yeah, you can remember that. Right. So that's how you have to remember that, right? So all immunoglobulin will be forming, the chain, but all these are the decreasing order in the sequence. Maximum IgG, minimum Ig, right? Now this M protein, which is forming light chain protein or monoclonal protein, they will come into the urine, right? And in urine they will be having two presentation, either Benz-Jones protein or they will be forming light chain deposition into the renal parenchyma. So either they will pass through in the urine as a Benz-Jones, right? Either they will be forming in the form of Benz-Jones or it will be forming a complex and deposited over the renal parenchyma, causing the damage, right? So Benz-Jones proteinuria, how you will identify? Benz-Jones proteinuria, how you will identify? That is the another important MCQ which is asked. So Benz-Jones, you will do two things. You will heat them at 50 degrees Celsius and then 100 degrees Celsius. Remember like this, half century and century. Heating them at half century, they will form the clot. Further heating up to 100 degrees Celsius, they will come back to the liquid state. Right? So examiner had asked this question. Urinary protein was heated at 50 degrees Celsius, forming the clot. 50 degrees Celsius forming the clot. Further heating up to 100 degrees Celsius, they are redissolved, coming to liquid form. Most likely, this is the Benz-Jones protein. Right? This Benz-Jones protein, when they are passing through the kidney, they will be deposited over the renal parenchyma. They will be deposited over the renal parenchyma. And this renal parenchyma will be getting destructed or damaged. And because of this light chain deposition, they will be giving amyloidosis. And this type of kidney is also called as myeloma kidney. So can you tell me, myeloma kidney is which type of amyloidosis? Primary or secondary? Primary or secondary? Those who are telling secondary, have you not read the amyloidosis lecture which I have taken? Okay, you tell me. Don't think that it is secondary to the deposition. That is why secondary. Why you are saying secondary? Tell me. Why you are secondary? What is this? Can I tell you what is this? Light chain. Light chain. So what type of amyloidosis? AL type of amyloidosis. AL type of amyloidosis. So what is AL? What is AL? Primary or secondary? Primary amyloidosis. Never do this mistake. Very commonly asked question in the NEET exam. Primary amyloidosis. It's light chain, huh? Recall that what I have told you in the amyloidosis classification of the amyloidosis, primary, secondary. Secondary is 2A, primary is having 1A and another is the L. L for light chain, L for light chain. You remember that wording which I used to say, that L for light chain of the immunoglobulin. So whenever light chain of immunoglobulin is coming, it means it is not a secondary amyloidosis, it's a primary amyloidosis, right? So do not have this confusion in exam. Don't commit this mistake. It's an easy question. Nobody is going to commit mistake who are going to get a good rank. Remember this point. So AL type of amyloidosis, myeloma kidney is the primary amyloidosis and AL type of amyloid will be positive. So now understood. This M protein light chain is coming in the urine, Benz-Jones protein, or they are causing primary amyloidosis, right? Now, whenever there is an excessive M protein is formed, right? This M protein will be deposited. So there will be excess M protein will be having increased cytoplasmic or nuclear, or you can say cellular accumulation. Right? So intracellular accumulation of the excessive amount of the M protein. So excessive amount of the M protein will be having intracellular accumulation. So some will be called as inclusions, and there are some important cells also. So what are the inclusions you are going to see in the multiple myeloma? So because of the excessive M protein accumulation, that there are two types of inclusion you are going to see. One is called Russell bodies and second is called as Richard bodies. So cytoplasmic M protein exclusion. See what I'm saying, that M protein in the cytoplasm. So M protein in the cytoplasm is called as Russell bodies. Cytoplasmic Russell bodies, and intranuclear accumulation is called as Richard body. Right? So now you can see increased M protein inclusion in the cytoplasm is called Russell body. In nucleus called as Richard body. Right? Now the question in AIMS exam was, Russell bodies are most commonly accumulation of the M protein in which organelle? Mitochondria or endoplasmic reticulum? Remember what I have told you. Plasma cells are rich in endoplasmic reticulum. So what is this? Endoplasmic reticulum. So Russell organelle, mitochondria or endoplasmic reticulum? Remember what I have told you. Plasma cells are rich in endoplasmic reticulum. So what is this? Endoplasmic reticulum. So Russell bodies are accumulation within the endoplasmic reticulum of the plasma cells. So what I'm showing you, all these are the plasma cells. All these are the plasma cells. So plasma cell, cytoplasm, Russell body, where in the endoplasmic reticulum. Right? Fine. And nuclear is the Richard body. Two things. Two inclusion, Russell body, Richard body. Done. Now come to the cell. If you find a cluster of grape, can you see there is a cluster of grape-like accumulation of the M protein within the cytoplasm? Right, cluster of grape-like, and this cluster of grape is basophilic, blue color. So cluster of grape-like blue deposit of the immunoglobulin or M protein is called as Mott cell. So this cell is called as Mott cell or morula cell. This is also called as Mott cell or morula cell. Morula cells, right? So now understood. Mott cell or morula cell is because of the cluster of grape-like basophilic deposition within the cytoplasm, right? Clear? Sometimes the immunoglobulin will be very red in color. So red color has become orange because of the PPT conversion, right? So when they are red in color, this will be called as flame cells. So fiery red deposition of the M protein is known as flame cell, right? So now understood. There are two types of cell. Cluster of grape like basophilic is the cluster of grape like basophilic deposit is Mott cell. Fiery red deposition into the cytoplasm is called flame cell, right? So now you can see increased M protein in the plasma cell is having two types of inclusion. Russell body in the cytoplasmic endoplasmic reticulum. Richard body is inside the nucleus. Cluster of grape like basophilic inclusion will be giving a named cell, Mott cell, morula cell. Fiery red deposition is giving flame cell. Clear? Right. Now, these are the picture. These are the picture which you should remember for your exam. So now you can see this is the normal plasma cell. We are not bothered about that thing. We are bothered about this plasma cell. What is this plasma cell? Can you see basophilic? These are not vacuoles. So you remember Shubham, I think somebody was asking vacuole. So these are not vacuoles. These are the immunoglobulin inclusions. immunoglobulin inclusions. So what are these things? These are the MOT cells, right? So this is how MOT cells will be looking. And these are the cytoplasmic inclusions. These are the cytoplasmic inclusions. So what are the cytoplasmic inclusions called as? Russell bodies. Now you tell me, can you see anything else? Anything else? Can you see the nuclear inclusion here? Can you see nuclear inclusion? Can you see this appearance of the nucleus just like outside? So this is the nuclear inclusion. This is the nuclear inclusion which is called as Russell bodies. Right. So now you can see there are three types of things we are seeing in the MOT cell. We are seeing cytoplasmic Russell bodies and intranuclear Russell bodies. Right. Clear? So that is how examiner will be asking. This was the question in the NEET exam 2016. Identify this cell, right? So similar cell was given in the Robbins, and the same cell was given in the exam. Identify this cell of the multiple myeloma patient, right? So that is the MOT cell, right? Now you can see this is the another cluster of grape is the Russell body only, right? This is the Russell body only. All these are Russell body only. All these are Russell body only. When they are looking like a cluster of grape, then we are giving them a specific name that is MOT cell. In simple word, you can say that MOT cell will be having all these things, right? So there is nothing to have any confusion, right? So now you can see this is the fiery red cytoplasm. Fiery red cytoplasm because of the monoclonal immunoglobulin deposition, and such cells are called as flame cells. So because of the fiery red deposition, they are called as flame cell. Russell bodies are not, no, it's not like that. These are also called Russell bodies only. This will be also called as Russell body only. Anything which is present in the cytoplasm, that's all, irrespective of the color. Whether it is a blue color, whether it is a green color, whether it is a fiery red deposition, they are all Russell bodies. So here also it is Russell body only. In the cytoplasm, they are having accumulation. It is the presentation of the cell which is different. Right? Fine. Most common site for multiple myeloma is the vertebral column. And most common cause of death, because all these are abnormal immunoglobulin, right? And because of abnormal immunoglobulin formation, there will be no protection from the infections, and these infections are the most common cause of death. So remember this point. These are the two important and very frequently asked questions in the exam. Most common cause of death is recurrent infection. It is not renal failure. I'm just marking here. It is not the infections, and these infections are the most common cause of death. So remember this point. These are the two important and very frequently asked questions in the exam. Most common cause of death is recurrent infection. It is not renal failure. I'm just marking here. It is not renal failure. Many of the guidebooks they say renal failure. If you go through all the textbooks in Harrison or any other book also, you will find that renal failure is the not most common cause. Recurrent infection is the most common cause of death in the multiple myeloma. Multiple myeloma, when we are checking the prognosis, right? Multiple myeloma prognosis will be assessed by these markers which I have written. So what are these markers? Beta 2 microglobulin. Beta 2 microglobulin is the best marker, best prognostic marker. Remember, it should not be confused at the best prognosis, right? So that is why I wanted to say that it is the best prognostic marker for multiple myeloma. Right? So beta microglobulin is the best marker for the beta multiple myeloma. Apart from this, C-reactive protein is also used, serum LDH is also used, cyclin D1 is also used. Right? So these are some important ones. Why you can notice that there are three in the green color and one is in different color. So these are all three are marker of the tumor load. These are all the tumor load marker. So what I mean to say that if you find all three are getting increased, means all three means any of them is getting increased. That means there is an increase in the tumor load, right? Increase in the tumor load, and whenever increase in the tumor load, what they are suggestive of? They are suggestive of bad prognosis. So that is the important thing which I wanted to tell you, right? So now you understood. Beta 2 microglobulin, C-reactive protein, serum LDH. All these are the tumor load marker. That was the NEET PG question in 2017. Which of the following is a tumor load marker in the multiple myeloma? Beta 2 microglobulin, C-reactive protein, serum LDH. All of the above, right? But the students they were not knowing about these two because not given in Robbins, so they took only this answer. So please remember, tumor load marker is all of them. That is why I wrote them together, right? So beta 2 microglobulin, serum C-reactive protein, serum LDH. All these are the tumor load marker. And remember, when they are increased, it means tumor load is more, and it means prognosis is bad because tumor load is more. Right. Now the cyclin D1. Another question in the exam, the DNB 2014 and 15 exam. This was the question. This is carrying the best prognosis. Number one. This is given in Robbins also. They are the best IHC marker, best immunohistochemical marker for multiple myeloma. This was the question in the DNB exam. Right. So I understood these are the two important MCQs. Cyclin D1 is the best for prognosis and best IHC marker for the multiple myeloma diagnosis. Right. In multiple myeloma. Right. Previously in my lecture, I used to say that deletion of the 13q is the most common change. But now you will find there is a change in the WHO update. So now new WHO update says that hyperdiploidy is most common. Remember, most common cytogenetic change in multiple myeloma is hyperdiploidy, and after hyperdiploidy, it is cyclin D translocations, which will be involving chromosome number 14. And after that, there will be now deletion of the chromosome 13 long arm. So now you understood? So this is the number, right? So this is the update beyond the Robbins. That is what I always say that my lecture you will definitely find something which is not given in the Robbins or not given in the Harrison. So these are the updates, and I'm telling you why I'm saying this aims people have the tendency to ask such kind of question. Or this INICET exam, you are going to get the question from here. So hyperdiploidy is the most common. Cyclin D translocation, second most common, and deletion 13 is the third most common. Right? See, this is the update from the WHO. This is the screenshot from the WHO book, right? This is the table. Now you can see that multiple myeloma genetic category hyperdiploidy is most common, 45%. Non-hyperdiploidy is 40%. And in that you can see cyclin D translocation 11, 14, 6, 14, 12, 14. So all the cyclin D translocation involving chromosome 14. That is why I wrote here also. So now you will be remembering this in your exam also. Clear? Fine. Now come to the diagnosis. D translocation involving chromosome 14. Non-hyperdiploidy is 40%. And in that so now you will be remembering this in your exam also. Clear? Fine. Now come to the diagnosis of the multiple myeloma. How we are going to give the diagnosis of the multiple myeloma? Multiple myeloma diagnosis can be given by, see here by mistake I have written CRAP plus minus MD. Actually I should have written like this. Multiple myeloma diagnosis can be given by myeloma defining events plus minus CRAP criteria. Because CRAP criteria is not very important. It is very important. Right? It is very important. So you can understand like this also. I'm just making it in the bracket. This is the most important. This is the most important criteria. Right? So how you are going to give the diagnosis of the multiple myeloma? Diagnosis is given on the basis of myeloma defining events. MDE means myeloma defining events should be present. Right? Should be present. Right? It should be present. Plus minus CRAP criteria can be also present or may not be present. Right? So that is what we have to remember. So myeloma defining event, there are three criteria. I will be telling you what are those three myeloma defining events. Right? So diagnosis of the multiple myeloma require any one of the three myeloma defining events. So as I said, there are three criteria. Out of these three criteria, any one is present. right? With or without crack criteria. So if you read this box, then it will be very clear to you, right? Any one of the three myeloma defining events plus or minus crack criteria will confirm the diagnosis of the multiple myeloma. I understood crack. Crack already. I have for the bone lesion, right? Now, what is the myeloma defining events? That is important. What is the myeloma defining event? So, myeloma defining event, there are three things, right? So, these are the updates not given in the Roberts. These are the WHO updates not given in Roberts. So, myeloma defining events consist of three findings. Bone marrow biopsy should be having more than 60% of the plasma cell. Can you see this? Now, what they are saying that bone marrow biopsy should be having more than 60% of the plasma cell. Number two, serum free light chain. So, now you are going to measure the free light chain in the serum. So, what you are going to measure in the free light chain? Uninvolved and involved. So, which are involved with the disorder, which are not involved with the disorder. And this ratio should be measured. And if it is equal to or more than 100, then it will be significant. So, serum free light chain involved divided by uninvolved. So, we can remember like this, right? I by U. Involved by uninvolved, right? Should be more than equal to 100 to say that serum free light chain is increased, right? And the third thing is MRI. So now, if you, I have seen it, right? I have gone for one of my father's bone pain, right? So that time when I gone to the clinician, the hematologist, he told me get the MRI done. Remember, he said that get the MRI done because he was showing the features of the MGUs, right? The plasma cell was borderline. This was also borderline. It was showing 100 exactly, right? So he was worried about that thing. It was long back, 2 years back, right? So he was persisting to ask this MRI scan because MRI scan will be showing you more than one focal lesion for more than 5 millimeter size, which was not seen in my father's report. So I understood this point. So more than one focal lesion, more than 5 millimeter of the size should be present to say that myeloma defining event. So now you see there are three myeloma defining event. What is number one? 60% of the more than 60% of the bone marrow should be having plasma cell. Number two is the serum free light chain involved upon uninvolved should be equal to or more than 100. MRI will be having more than one focal lesion, and more than 5 millimeter size. Involved means monoclonality is there, mutation. Uninvolved means they are not monoclonal. That is the meaning. Involved means they will have mutation. Involved means monoclonal protein. If they have mutation, then only they will become monoclonal. If there is no mutation, they are uninvolved. So suppose IgM, for example, if you are talking about, so you are talking about IgG, right? So IgG involved and IgG uninvolved. Involved means mutant, monoclonal protein. Involved, uninvolved means that normal reactive type of things, right? So that is what we are going to measure here. So now I think hope you all understood about this. These are the three myeloma defining criteria which should be present. So now you understood. So any one of the three myeloma defining event with or without crack criteria is present or not does not matter. You should have just myeloma defining event, right? So three myeloma defining criteria should be seen, and any one of the three myeloma defining event with or without crack criteria will confirm the diagnosis of the multiple myeloma. Multiple myeloma, as I have told you, most common site is the vertebral column, so it's a basically lymphoma, right? It's a basically like a lymphoma. MD, you want one more time? Okay. Myeloma defining event is three things: bone marrow biopsy, serum light chain, and MRI. Bone marrow biopsy, more than 60% of the plasma cell. Serum free light chain should be more than 100 when you are seeing they're involved and uninvolved. Involved means mutant, abnormal one, tumor one, and uninvolved is the normal one. So uninvolved ratio should be more than or equal to 100. MRI scan, when we are seeing MRI scan should be having more than one focal lesion, and that focal lesion should be more than 5 millimeter in size. Involved means mutation. They should have mutation. Abnormal mutation will be present. The tumor one, and uninvolved means normal one. So you have to check the tumor divided by normal. More than 100, right? Fine. So as I was telling you, multiple myeloma is like a lymphoma, and if they will involve the peripheral blood. So remember, neoplastic plasma cell in the peripheral blood, they are called as plasma cell leukemia. Remember, this is the diagnostic criteria for the plasma cell leukemia. So this is the WHO criteria for the plasma cell leukemia, and this was also questioned in the AIMS exam. So here I will tell you one thing: many students they get always confused, and this is a very dangerous question. 2014 and 15, this question came twice in the AIMS exam. Please be careful. Plasma cell leukemia criteria is different. Multiple myeloma criteria is different. Please do not confuse with these two things. Otherwise, you will be damaging your result in your exam. So please remember, please do not confuse with these two things. Otherwise, you will be damaging your result in your exam. So please remember, plasma cell leukemia, it means plasma cells are only present in the peripheral blood. Multiple myeloma means it's like a lymphoma. There is a different presentation. Their diagnostic criteria, I have told you, CRAB plus myeloma defining events, right? But plasma cell leukemia is very easy. There is only one criteria for the diagnosis of the plasma cell leukemia. Either you should have absolute plasma cell count more than 2 into 10 to the power 9 per liter, or peripheral blood plasma cell should be more than 20%. That's all. This is conversion only, but remember the diagnostic criteria is different. See why I am saying you, because when this patient will be coming, he will be having only one finding like this. That's all. And if you are not treating him, if you are waiting for I will do the bone marrow biopsy, then he will be gone after some time. Gone means he will be dead. Right? So I understood. That is why it's a leukemia lymphoma conversion only. But in this thing, WHO has taken one step because their prognosis is different, right? Prognosis is different. That is why you have to earlier identify and you have to earlier start the treatment. If you are waiting for them to develop to involve the bone marrow, then it will be very late. So that is why plasma cell leukemia will be the very, very important step. And there is only one criteria: either peripheral blood should have more than 20%, or absolute plasma cell count should be more than 2 to 10 per 9 per liter. Right? I'll just tell you what was the question in the AIMS exam. I have seen and I was discussing in our Telegram group, and students were not understanding. More than 20 means it can be more than 60. No. Why you are confusing? That is the bone marrow biopsy, Papa. See this is the bone marrow biopsy. And I'm talking about the peripheral blood. This is the peripheral blood. Diagnosis in the peripheral blood. Right? It's not there. So see this. I'll tell you the question. You will understand. 35-year-old female. Right? Bone marrow was showing plasmacytosis. See, examiner is not talking about how much plasma cell is increased. Plasmacytosis can be because of the infection also, right? Examiner is saying that bone marrow is showing plasmacytosis. There is a sacral lytic lesion. So plasmacytosis, sacral lytic lesion. Peripheral blood examination was done. She was having 35% of the plasma cell in the peripheral blood. What is your diagnosis? First option was multiple myeloma. Second option was plasma cell leukemia. So tell me, what should be right answer? I understood. So now it is, see, please don't understand, please do not get confused that thing. Bone marrow is a different thing. Peripheral blood is a different thing. Don't mix both things together, otherwise you will not be understanding. Bone marrow is a different thing, right? Bone marrow is a different thing. Peripheral blood is a different thing. Now understood? So this answer is plasma cell leukemia. So that was the question in the AIMS exam. So this is the same question I have seen just few days back when a student was asking, and they were not agreeing with my answer. I'm so surprised. These are not my points. These are the points given in intro, right? So please do not have this kind of confusion. Are Baba, plasma cell, you will never find a single percent in the normal plasma, in normal blood. Okay, I'll just write it down. Have you ever seen normal blood, normal peripheral blood, whenever you go for DLC, right? Have you ever seen your pathologist writing plasma cell? If you see a single plasma cell, you will start jumping, oh my god, who is this? Right? So there, normal peripheral blood, there is no plasma cell, Papa. Remember this point. No plasma cell under normal condition. Now, understood? So if you find more than 20%, definitely it is a leukemia. Less than 20%, it can be because of the inflammation or some other abnormalities. But that is why WHO has taken this step. Try to understand this point. Be clear about this and please follow this. Otherwise, you will be committing mistake in the exam. There should be no deviation. Please don't, after exam, please don't say that, sir, I was not confident about this point. Please be confident. If you're not confident, check into the intro also. And you have to go like this only in your exam. That is the reason, that's what I said, that the plasma cell leukemia and multiple myeloma, this is the only difference you will find. In multiple myeloma, you will be having clear-cut finding. You will be having bone marrow biopsy more than 60%. You will be having unwall area will be there. MRI will be showing the bone light lesion more than 5 mm. You will be having the presence of the crack criteria. But when you are having nothing, you are just seeing one thing, that plasma cell is more than 20%. That's mean, that's all. It's a plasma cell tumor. Right? Fine, I think we should finish off. Otherwise, it will keep going on. What is strong macroglobulinemia? This is the another, immunoglobulin disorder, that IgG immunoglobulin disorder. When you find what is strong macroglobulinemia is a leukemic form, right? This is the leukemic form, right? And when they will involve the tissue or the lymph node, they are called as lymphoplasmacytoid. Remember, lymphoplasmacytoid lymphoma, right? Lymphoplasmacytoid lymphoma. And what is characteristic of this tumor? What is characteristic of this tumor? They will be having increase in the monoclonal IgM synthesis, right? So increase in the monoclonal IgM synthesis is the characteristic. So these are the B cell neoplasm, same like the multiple myeloma. Older patient will be there, right? Older patient will be there, and because of the increased monoclonal M protein, they will be having hyperviscosity. Hyperviscosity will be similar to prognosis will be poor in both plasma cell leukemia and multiple myeloma. Prognosis will be both poor in the plasma cell and multiple myeloma. There is no difference. So characteristic finding is the increase in the M protein, and because of the IgM M protein, there will be hyperviscosity, and this hyperviscosity is the reason for the visual disturbances and the neurological deficits. Because blood vessel, when hyperviscosity is more, so blood flow will be less, and because of the blood flow will be less, if there it is in the retinal artery, then it will be having problem in the vision, and that is why there will be visual impairment. And when blood flow will be less, there will be causing CNS problem also because of the hypoxia ischemia, right? So now I understood this Waldenstrom's macroglobulinemia is leukemic form where B cell neoplasm and older patient, and characteristic will be the monoclonal IgM protein will be there, and this is the reason for the hyperviscosity and all these clinical findings. Right. So what is macroglobulinemia? This was previous year JIPMA question. They are having association with the MYD88 gene mutation. So remember, MYD88 gene mutation is acquired mutation. So acquired mutation in the MYD88 is seen in Waldenstrom's macroglobulinemia. That was the question. And remember, this can be the future question. What is the most common cytogenetic change? Most common cytogenetic change is 6 long arm deletion. Right. So they are associated with MYD88, and most common cytogenetic change is the 6 long arm deletion. Right. Here, what is the problem? Heavy chain and light chain, they are equally affected. See, multiple myeloma, light chains are commonly affected. That is why they are having all those amyloidosis, bone lysis, all these features are because of light chain. Right? Here, heavy chain, light chain are balanced. They are balanced, and that is why all these features, bone lytic lesion, anemia, renal failure, all these findings are absent. Right? So this is the very important differentiating feature between Waldenstrom's versus multiple myeloma. Right? Waldenstrom's macroglobulinemia, because IgM antibody is there. So what kind of autoimmune hemolytic anemia you will see? Cold type, right? So always remember cold type of autoimmune hemolytic anemia because of the hyper IgM. And on bone marrow biopsy, as I have told you, lymphoplasmacytoid. So lymphocyte, plasma cell will be increased, and there will be a characteristic increase in the mast cell. So mast cell hyperplasia will be also present in the bone marrow biopsy of the Waldenstrom's macroglobulinemia, right? I think this much is enough for today. Tomorrow, because the next topic is the larger one. So tomorrow we'll be finishing off with all the other things, right? I hope you understood that plasma cell, please